Let's talk about thiazide diuretics. We have hydrochlorothiazide, chlorthalidone, and metolazone. The mechanism of thiazide diuretics, they inhibit the sodium chloride reabsorption in the early DCT. Okay. It inhibits, we have a channel here that is, let me put it this way. We have a channel here. Well, it's so small, I don't know, but we have a channel here that reabsorbs the sodium and the chloride from the urine. That's a normal active reabsorption. But thiazide diuretic would inhibit this channel. So now the sodium is going to go out in urine and the chloride is going to go out urine. But again, we know that sodium is going to be picked up in the collecting tubules. So let's read. Thiazide diuretic is going to inhibit the sodium chloride reabsorption in early DCT, which leads to decreasing in diluting capacity of a nephron, decrease in calcium excretion. I mean, all they're trying to say is that it doesn't do anything with the calcium. So it's not going to cause hypocalcemia. So let's read. Adverse effects: hypokalemic metabolic alkalosis, hyponatremia, hyperglycemia, hyperlipidemia, and hyperuricemia and hypercalcemia, and self-allergy. So the mechanism behind all of these adverse effects is simple. So this one, there's one other mechanism. I think it was the potassium. It upregulates potassium channels or something with the potassium. Okay, on the channels. So remember that we have those potassium channels on the pancreas that secretes insulin. So when we block them, we are going to get no insulin or less insulin. When we have less insulin, we are going to cause hyperglycemia and hyperlipidemia. Okay, that's there. Hyperuricemia is due to the fact that all of these diuretic of any drugs, or any drug, more likely a lot of drugs, they use a transporter in the PCT, proximal convoluted tubule, to get secreted into the urine. So when you use up the transporters, and also just remember this uric acid or uric acid also uses the transporters in the PCT. So when the drugs come, they use those transporters. So uric acid remains in the body. When it remains in the body, it causes hyperuricemia. Okay. So that's what we have for thiazide. But the thiazide, remember, it inhibits the sodium chloride. What are the clinical uses? Again, hypertension, heart failure, idiopathic hypercalciuria, nephrogenic diabetes insipidus, and osteoporosis. Okay, so that's pretty much all we have for thiazide diuretic.